Hello, my name is Jae-young Park and I'm working for Korea University College of Medicine and Korean University Ansan Hospital. This time, I would like to talk about our study recently published in Korea Journal of Urology 2015 June. Before that, I must say I appreciate the editor-in-chief, Dr. Park Kwang-sung, who gave us this great opportunity. Thank you very much, Dr. Park. Okay, now there are two other doctors here. Could you introduce yourself?
Hello, I'm Dr. Shim and I'm the first author of this manuscript.
Hello, I'm co-author and my name is Dr. Choi.
Okay, well, before we go into main topic, I heard that Dr. Choi have something to talk about our team. Dr. Choi, could you explain?
Urologic department of Korea University Ansan Hospital has progressed in many ways. We are sure of medical providers and we do not have residentship doctor. But in 2014, we did more than 900 general operations and we are still growing up now.
Thank you, Dr. Choi. Okay, now we're gonna talk about our study. The title is The Clinical Significance of Second TUR for T1 High-Grade Bladder Cancer. Recently, several guidelines recommend considering a second TUR BT if there is concern that the initial resection was incomplete. This slide came from NCCN guideline for bladder cancer. If clinical stage is T1 high-grade, guidelines strongly advise to repeat TUR BT or even cystectomy for high-grade cancer. High-grade T1 is a life-threatening cancer. Yes, we all know it definitely. So, the objective of this study is to estimate the value of second TUR BT in patients with initially diagnosed T1 high-grade bladder cancer. From now on, Dr. Shim will talk about method, result, and conclusion. Dr. Shim, please.
Let me tell you about methods. Between August 29 and January 2013, 29 patients with T1 high-grade bladder cancer prospectively underwent second TURBT. Evaluation included presence and location of previously undetected remnant lesions, changes to pathological grading or staging, and rates of recurrence-free and progression-free survival after a second TURBT procedure. This is the table about clinical pathological characteristics of the patients after first TURBT. A second TURBT was conducted within 3 to 8 weeks following the first operation. The muscle layer was included in the surgical specimen after initial TURBT in 24 patients. In 3 patients who upstaged to T2 after second TURBT, their initial surgical specimen contained the muscle layer. In 29 patients, 22 patients had residual disease after second TURBT. 18 patients had a residual lesion at the same site, and 2 patients had lesions at other sites. The remaining 2 patients had residual tumors at the site of the first TUR and another site. These figures represent Kaplan-Meier curves of recurrence-free survival and progression-free survival respectively. The green line showed the group with residual tumor, and the blue line showed the group without residual tumor at the second TURBT. In group with residual lesion, 3-year recurrence-free survival and 3-year progression-free survival rates were 50% and 67%, while 69% and 69% respectively in group without residual lesion. In conclusion, initial TURBT does not seem to be enough for controlling T1 high-grade bladder cancer, and second TURBT can detect residual cancer and provide accurate pathological information. Therefore, a routine second TURBT should be recommended in patients with T1 high-grade bladder cancer.
In our trial, 30% of patients with no macroscopically visible tumors by cystoscopy and 40% of patients with negative cytology result were found to have a residual tumor on second TUR. These findings support the evidence that urine cytology and cystoscopy are not sufficient to find the remnant lesion after the initial operation. Some urologists do not perform second TURBT routinely. It needs readmission and repeat anesthesia. Furthermore, the patient or their family may be suspicious when they hear that the patient needs another surgery. In the author's experience, the explanation about second TURBT before the initial operation was helpful for patients or families' decision making. If they are told that the second TURBT is already planned and it is totally consistent with state art guideline, they can follow doctor's decision for second TURBT easily. Thank you for your listening, and I hope our study will improve your daily practice. Thank you.